Our next speaker is Dr.Chee Phaik, and she is going to, in the next 15 minutes, tell us A to Z of managing traumatic cataracts in adults. A very tough challenge for you, Doctor. On to you.
Yeah, thank you so much for having me. I hope you can see my screen. Yeah. Okay, so I've pre-recorded this. Hello, everyone. First of all, I'd like to thank Dr. Chitra and the organizing committee for inviting me to speak on the A to Z in managing traumatic cataract in adults. These are my financial disclosures with no relevance to my talk today. Lenticular trauma may be caused by a penetrating injury or blunt trauma. Regardless, these are the structures that may be injured, but more commonly, penetrating injury can injure just the anterior lens capsule or both anterior and posterior lens capsule, and also iris injury. In addition, there may be an intraocular foreign body present. In blunt trauma, more commonly, the zonules and the iris are injured. Penetrating injury to the eye is an ocular emergency. We should restore the globe integrity and rule out infection and a foreign body if present. There is no consensus regarding the best timing for lens surgery in penetrating injury. However, if there's content spillage into the anterior chamber or vitreous cavity, we should remove the cataract and vitreous and foreign body if present as soon as possible. We should leave the eye aphakic during this repair so that we can attend to the retina. If there's limited content spillage, we want to delay lens surgery for as long as possible, at least for 2 weeks, even if the lens is becoming intumescent. During this time, we want to exclude infection, reduce inflammation, allow the corneal scleral laceration to heal, the capsule laceration to fibrose, and also to obtain reasonable biometry. If there's focal injury or no spillage, we want to delay and remove the lens only according to visual needs, like what you see in this picture here. This eye has a corneal laceration that involved the lens anterior capsule, resulting in spillage of lens material into the anterior chamber, sparing the posterior segment. At the time of surgery, we stained the anterior capsule with trypan blue dye, and we released the posterior synechiae using Kuglen hook initially, and then capsulorhexis microforceps, and we peel the iris from the lacerated lens capsule as well as the spilt lens material. Then we initiate the capsulorhexis with an incision into the cut anterior capsule, and then complete the capsulorhexis, tearing to the other end of the cut anterior capsule. We then remove the soft lens material by aspiration using an INA, and in the area where there is no anterior capsule, we use a flushing technique with a 27 gauge cannula and BSS, and then aspirate the prolapsing lens material, and we inject the single piece hydrophobic acrylic lens into the capsular bag, ensuring that the haptics are completely covered by the lens capsule. And then we release the synechiae completely from the lacerated lens capsule so that the iris comes down and the pupil is round. This is how the patient looked after surgery. This patient sustained a corneal laceration, injuring the lens capsule, and developed a localized lens opacity 1 day after toilet and suture. 3 days later, the lens opacity became more diffuse and then became intumescent, but we managed to hold out until 10 days later when we had to bring him to surgery. On the table, after having stained the anterior capsule and opened up a capsulotomy like what I showed you in the previous case, aspirating the lens material, and you can see a very strange kind of surge appearing in this dissociated aspiration infusion, and you can now see this is because I had aspirated a strand of vitreous that was present in the anterior chamber amidst the lens material, and so I'm using scissors now to cut that strand of vitreous which is extending to the corneal laceration and then staining the rest of the vitreous in the anterior chamber with 50% diluted triamcinolone. I then do vitrectomy to remove the rest of the vitreous, inject dispersive viscoelastic, and then round off the leading edge of the posterior capsule rip caused by the injury, and remove the rest of the lens material with the aspiration mode of the vitrectomy. And then very carefully now in this area where the laceration is, I then cut a little more to ensure that there are no residual strands of vitreous leading to the corneal laceration that has been repaired. I then release the iris that has been injured from the lacerated cornea and repair it with a single pass 4-throw pupilloplasty, so that the iris and the pupil is now becoming rounder and smaller. And at this point in time, I evaluate the supports that I have left and realize that I cannot put the lens in the bag, and therefore I'm inserting a 3-piece IOL into the sulcus. I manipulate the haptics from the anterior chamber into the sulcus and then do a iris fixation using 10O polypropylene suture and modified Simpson knot. So I retrieve a loop of the suture and put 3 throws, and I do the same for the opposite side before finalizing the knot once I'm sure the IOL is centered, and then do a reverse and 1 forward throw to finalize the knot. And then now we're adding an additional suture to the iris to repair it further to make the pupil round. And you can see here at the end we have a reasonably good outcome. So this is the post-op appearance. Blunt trauma most commonly causes zonulisis with or without iris injury. It's important to examine the patient both upright and supine, because you may be surprised that the lens is not visible when the patient is lying down. Ultrasound biomicroscopy is a very useful examination for patients with zonulisis. It gives you an image of the lens when the patient is in a supine position. So you can see, for example, a lens that is dangling here, and it can also show you the location of zonulisis and also the extent of zonular loss, whether it is partial or complete. And you can see examples of partial zonular loss and complete zonular loss, and also the presence of vitreous in the anterior chamber. Generally, which is more useful, iris hooks or capsule retractors? I prefer capsular hooks because they support the equator. However, if we only have iris hooks available, we can combine a CTR with 4 iris hooks, or we can use 2 capsular tension segments supported by 2 iris hooks to provide a similar support. In addition, iris hooks can provide counter traction during capsulorhexis. So, how to decide the
Can you mute yourself,
this
everybody?
depends on the extent of zonulisis and the strength of the remaining zonules. I use the 4 clock hour rule, and I can mix and match the devices. So if it's less or equal to 4 clock hours of zonulisis, a capsular tension ring is adequate. More than 4 to less than 8 clock hours of zonulisis, 1 point of fixation is needed. If it is more or equal to 8 clock hours of zonulisis, 2 points of fixation are needed. We should always use a permanent suture, and I prefer to use Gore-Tex 7O, and this is off-label use for scleral fixation. However, it has excellent longevity. Polypropylene 9O may be used, but it may not last. We should avoid polypropylene 10O. The needle of a 7O Gore-Tex suture is thick and short and inappropriate for ophthalmic use. How do we then bring the suture loaded on the tension device to the scleral fixation point without the needle? So if we have got a needle that is already preloaded with a segment of suture, we can extend that and use it to lasso the end of the suture and bring it to the scleral fixation point like what you see here. And this is a suture snare that has been described in the British Journal of Ophthalmology. This eye has 5 clock hours of zonulisis and a rosette cataract. After initiating the capsulorhexis, we then use an iris hook to support the rhexis as we tear the rest of the capsular rhexis and support the capsular bag with iris hooks, but the equator is not supported, and therefore we use visco dissection to release the cortex. And now we support the equator by inserting a Sioni 1L capsular tension ring, which has been loaded with polypropylene suture. I would recommend you use 9O if you use polypropylene suture, and then insert the intraocular lens into the capsular bag. We then create a Hoffman pocket for fixation at the site of greatest weakness. This is half scleral thickness. And then we mark 1.75 mm posterior to the limbus. We do an external kind of fixation technique with a 27 gauge needle, railroading the polypropylene suture into this, and then retrieving sutures from the Hoffman pocket and finalizing the knot to center the lens. This patient with more than 8 clock hours of zonulisis has the lens tipping into the vitreous cavity following blunt trauma. First, we start by removing vitreous using a 23 gauge cutter through a past planar approach using a trocar cannula, staining the vitreous with triamcinolone acetonide 50% diluted. Then we harpoon the anterior lens capsule with a 27 gauge needle and bring it to the anatomical position. Following which we do bimanual capsulorhexis using Kawai micro capsulorhexis forceps and a micro grasper that is non-toothed. And as we move along, we suspend the lens using capsule retractors and iris hooks, and we look at the equator for a guidance as to the shape of the capsulorhexis as well as the size. Then we switch to capsule retractors to suspend this lens, and following which we inject dispersive viscoelastic just under the anterior capsule and introduce a capsule tension ring into this space to support the equator. Once we have done that, done some hydro dissection, we then create a trough with the vacuum-emulsification, crack the nucleus into half, do a cross chop now to create 2 quadrants on the right side, remove the quadrants without rotation of the nucleus, emulsifying the fragments. And finally, we clear the cortex, which comes off quite cleanly from the capsule, as the capsule tension ring did not trap any of this. And then we inject the single-piece hydrophobic acrylic lens into the capsular bag, create a suture snare using 26 gauge needle that has been loaded with a Gore-Tex 7O suture. Then we create 2 Hoffman pockets, which are diametrically opposite. Load the capsule tension segment with Gore-Tex 7O. Use the suture snare coming 1.75 mm posterior to the limbus. We extend a loop of suture out through the main incision and use this loop to lasso the end of the suture loaded on the capsule tension segment through to bring it to the scleral fixation point. And this is repeated so that we can insert another capsule tension segment into the capsular bag. And we do it in a similar fashion using the suture snare. And once we have done this, we can then tie 2-on-1 knots, first adjusting the tension of the 2 knots to center the intraocular lens after retrieving the sutures from the Hoffman pocket. So this happens to be a toric lens, and you can see its alignment is in an appropriate meridian. Then remove dispersive viscoelastic and the trocar cannula. This is to show you Canabrava's double flange technique using a 27 gauge needle and polypropylene 6O, marking 2 mm posterior to the limbus. We then go in with the needle and extend the suture out through the main incision, thread it through the eyelet of a capsular tension segment, and insert the tension segment into the capsular bag. And then at a diametrically opposite point, we do the same. And here is the entry of the needle, and we extend the suture out, thread it through a capsular tension segment, flange the end, and then insert it into the capsular bag, and then cut the other end of the suture after ensuring that the lens is centered. So we leave 3 mm and flange it down, and the same for the other side. And then we push the end of the flange into the scleral tunnel. So in summary, for penetrating injury involving a laceration of the lens capsule, delay surgery as much as possible. Use iris hooks or bimanual capsulorhexis for severe zonulisis. Use capsule retractors to support the lens equator. Stain with 50% triamcinolone acetonide the vitreous and clear it with vitrectomy. Inject capsular tension ring early into the capsular bag in severe zonulisis to support the equator, and use Gore-Tex 7O and ensure that the knot is well buried. Thank you very much for your attention.
Thank you very much, Doctor. I mean, amazing videos and mind-boggling skill. Amazing. The first video really told us that like how to avoid an optic capture, how you combine it with pupilloplasty if there are iridolenticular adhesions. But some two basic questions I would want to ask. When would you defer placing an IUL in the first sitting and rather do it as a secondary procedure?
So I think at the time when the patient presents acutely, the main thing is to repair the globe, to restore integrity, and also, especially if we are very concerned about any kind of infection, I think I would avoid, trying to put a lens in. So if there is lens spillage, that's quite a lot, then we have really no choice. We have to actually evacuate all the lens material to reduce the inflammatory response. However, if there is just a small little puncture in the lens, like what I showed there, a little hole in the iris, that has gone through the lens, that can easily self-seal. So that can be delayed to another day. So really, if the case is such that, we have to remove the lens because it's really badly injured and spilling out into the anterior chamber, then we have no choice. We have to deal with it. And generally, we would not be able to have accurate biometry. So I don't think really there's a rush to put an IOL in if we're doing it in the middle of the night.
Dr. Grover, how would you calculate IOL power if there is a central corneal scar or a corneal tear? Dr. Ashok? Is not there, I think. Okay, Dr. Chee, you could tell.
Well, I think it's really very, very tough. And that's why we don't do, yeah.
So what do? You do take how do you plan your IUL in such a case?
So we usually look at the fellow eye,
right.
which, just for guidance. If not, we put in the K readings as 44 diopters. Yeah.
Okay. Yes,
yeah,
right.
so that's a nice, usually, I mean, that's done, you take the fellow eye, but sometimes the astigmatism is so much, you have corneal scar running through the center. Yeah. So in those cases, I mean, people have described when you do a secondary procedure like a contact lens method. So you put you can say, hard contact lens, which neutralizes the astigmatism, and do a retinoscopy then. So that would give you one option. But sometimes you have scars running through the center and you have the visual axis not clear. So probably a better option there is like a pentacam, where you can see the central area and you can adjust your keratometry according to what readings you are getting through the central 3 millimeters area. So that's what's been described in literature to have in these cases when you want to do a keratometry without taking the other eye reading.
Yeah.
Usually in these cases, they have a flat cornea and irregular cornea. But I think, Dr. Sukija, we also follow the same. If it is possible to take a reading of 2 to 3 millimeter of the central cornea by pentacam, that we use that reading. But if it is right in the center of the cornea, it is very difficult, and extensive tear, it is very difficult. And fellow eye reading is what Dr. Chee has said. I think we have to take that only into consideration.
Okay, thank you.
So it varies from case to case. That is what it is. It varies from case to case. You cannot generalize it.
Also, I was wondering whether, can you put a toric IOL? Because, when the healing happens, the access might actually change. So I think I saw the toric IOL being implanted, but, how do you ensure that the access is going to be the same?
The toric lens was actually for the blunt trauma, the subluxated lens. Yeah, they do very well.
Dr. Chee, wonderful surgery you have shown. And it looks like you say, never say give up. I saw that dangling cataract. You picked it up with the left hand. You completed the rhexis. You put the capsular hooks and did a phaco. So my question to you is, until what clock hours of zonular dialysis, like the dangling cataract you have, you can do this technique? Rather than just giving it off to the vitreoretinal surgeon, they can just do it, the vitrectomy, and then put a scleral fixated IOL, rather than doing this, because it seems very challenging.
Okay, so I did one patient yesterday, and that patient had only 1 clock hour. I think if the lens is not very dense and you have a reasonably good red reflex when you're trying to do the capsulorhexis, it's not as challenging. You know, once you grab hold of the cut end of the capsule that you've actually lacerated, you know, with the 27 gauge needle when you bring it forward, it's not so difficult. Yesterday, I struggled because the cataract was pretty dense. And when I hooked up the capsule with the iris hook, just to support it, the weight of the lens actually caused that capsule, you know, rib to actually extend on its own because it was weighing down, you know, when I was preparing my other instruments. And, you know, the red reflex didn't help because it was a pretty dense cataract. So sometimes you just can't get away and you have no choice. And I try not to call the retina surgeon, and what I do is I'll just bring it to the anterior chamber. I put in a 3-piece IOL into the over the iris, and I just Phaik over it. So if it was really very bad, I'll just do an IOL scaffold and then do a Yaman fixation.
Very heroic surgery. And when it comes to the Canabrava technique versus the Gore-Tex, which you showed the both when you're fixing the CTR, what do you think is the longevity of these two techniques? You prefer the Gore-Tex being better and you get a better control to make a central fixation, or with the Canabrava you seem to have the more central fixation and more control?
Okay, so this is an excellent question. And of course, when there's a new technique, I'm always game to try. So I use the Canabrava technique, and you know, exactly as you said, it's really difficult to titrate that length of that you know, suture that you're flanging, because, you know, if it's too loose, you cut off the end of the flange and then you don't have that much left to flange, and then you will make it too tight. Whereas with Gore-Tex sutures, like, you know, we can always adjust the tension to center the IOL, so we get a much better centration with sutures. And I think Gore-Tex has been around for many years now, and I use it, you know, I wanted to learn how to use it because of the pediatric cases that we're doing it for, and, you know, we want it to last a lifetime. And I think it has really great longevity. Whereas for the Canabrava flange, I'm just worried sometimes, you know, that flange may even slip through. Yeah. And, you know, can even slip through the capsular tension segment eyelet. Yeah.
Got it.
Thank you very much, doctor. That was wonderful.